Hi everyone. Thanks for joining us today at the launch of the Mental Health Coordinating Council report, Shifting the Balance, Investment Priorities for Mental Health in New South Wales. My name's Carmel Tebbutt. I'm the CEO of the Mental Health Coordinating Council and I will be your host today. So I would like to begin by acknowledging the traditional owners of the land that we're meeting on. For me, that's the Gadigal people of the Eora Nation, but of course it will be different depending on where you're zooming in on. We've had a great response to this webinar, so we've got people coming from right across New South Wales. I'd also like to acknowledge the contribution of people with a lived experience of mental health conditions to mental health reform in Australia. I'd now like to ask our speakers and panellists to join us, and I will briefly introduce them and we'll hear from them shortly. So we have Andrew Dempster, who is the Health Principal Director with KPMG. We have Priscilla Brice, who is the CEO of Being Mental Health Consumers. And we have Peter Gianfrancesco, the New South Wales State Manager of Neami National. So thank you all for joining us today. So as I said, today we are launching the latest report from the Mental Health Coordinating Council, Shifting the Balance, Investment Priorities for Mental Health in New South Wales. And MHCC have developed this report because we want to make the case for increased investment in mental health services in the community. We know that over the last few years, there's been a significant increase in investment in mental health services, both in New South Wales and also across Australia. But we also know that people still struggle to get the services they need in a timely way. And this was borne out by the Productivity Commission inquiry into mental health, which found that there were, or estimated that there were 150,000 people across Australia missing out on psychosocial support services. So for New South Wales, the share of that's about 50,000 people. So that's a lot of people who are not getting the support and services they need when they need them. Now, we know that there are great services and programs out there. Many of you involved in this webinar would be a part of delivering those services. For example, a recent evaluation of the HASI CLS program found that not only did it improve outcomes for individual participants, but it also resulted in cost savings of about $86,000 per person over 5 years. So there are good programs, but they need to be scaled up and they need to be more available to people who need them when they need them. So we've developed this report. We've worked with member organisations and we've worked with KPMG, who've provided research assistance in order to be able to contribute to the debate about mental health reform in New South Wales. The report outlines our 4 key priorities and it makes an economic case for additional investment. So I'd now like to ask Andrew Dempster, the Health Principal Director at KPMG and who leads their mental health advisory practice, to talk about the report in more detail. And then after Andrew's presentation, we'll have a panel discussion about some aspects of the report. So if you've got any questions that you want to have discussed in the panel discussion or that arise during Andrew's presentation, please put them in the Q&A function and we can deal with those in the panel session. So thank you. I'll hand over to Andrew. Thanks, Andrew.
Terrific. Thanks, Carmel. And good morning, all. It's really good to be here with you this morning. I would also like to acknowledge that we meet on Aboriginal lands and pay my respects to elders past, present and emerging. I'm here on the lands of the Wurundjeri people of the Kulin Nation. And I'd also like to extend that respect to Aboriginal colleagues on the call with us here today. I would also like to acknowledge people with a lived and living experience of mental health, their carers, family members and loved ones, and the contribution that they make to the workforce, to reform and to the activity that the New South Wales Mental Health Coordinating Council have. I'm going to step us through the report in a little bit more detail. So I'm just going to share my screen. Bear with me while I bring up the slides and just turn on the presentation view. Just to give you an overview, I'll be stepping through the 4 main areas that we have in a moment, and also provide a bit of background and context beyond the initial comments that Carmel's made. So really there's been 4 areas of critical focus for investment and enhancement in New South Wales. Psychosocial supports in the community, step up, step down services, youth services, and then more broadly and critically workforce. In terms of the background and some of the key context, as Carmel's already highlighted, the Productivity Commission estimated 154,000 Australians would benefit from psychosocial supports who are currently missing out. And when we look at the per capita numbers for New South Wales, that equates to almost 50,000 people who are missing out on those support services who would benefit from them. But the broader context, when we think about the population of New South Wales and the fact that 16.7% of the over 8 million people living with high or very high levels of psychological distress, it reinforces the need for comprehensive services beyond clinical and online support services, and really reinforces the need for enhanced community managed psychosocial support services. When we look at the spend per capita across Australia, New South Wales is extremely low. So New South Wales, for those who can't see, the bar on the left of each year is sitting just below 20 per capita in terms of the spend on community managed services, and that's looking at the grants and the to community managed services and the spend on community-based facilities. So there's a need to really look at the balance and the shift towards greater investment in community managed services. And I think that's highlighted through the increasing rates of emergency department presentations for mental health. And that's been increasing year on year, noting that we've had some anomalies in the last 2 years given the COVID impacts on emergency departments more broadly. I think the surveys and the lag of service demand that we're seeing is really reinforcing that COVID is having longer impacts and also greater impacts on psychological distress over the last certainly year and a half. And that's impacting people disproportionately for some cohorts. So particularly, as an example, the rates of mental ill health in young people. I know the recent ABS research has highlighted the rates of young people presenting to emergency departments as increasing, and ultimately reinforces that need for people who are missing out on not just acute clinical services, but also those really important practical and supportive psychosocial supports in the community. When we look at psychosocial supports in the community, I think importantly, it's about that holistic support that's being provided for people living with mental ill health at varying levels of acuity. And I think, again, importantly, presents a real alternative and a needed community-based support service for those who are at the moment struggling to get the service that they need and the support that they need through emergency departments and crisis services. And I think what we've looked at here in the research is the recent studies that were done on HACI and CLS services and the evaluations that have been conducted over a number of years now that show the benefits of introducing the HACI and CLS supported services, reductions in mental health related presentations for those who are part of the program. When we look at that, that actually extends following 2 years of involvement in the program. So that's not something that sort of happens and then falls away, actually continues on given the supports that people are receiving. And I think importantly as well that we see extensive savings in the program where it actually more than pays for itself. When we look at the savings that are occurred of over 31 million per annum, when we looked at the program that was spent of 118 million over a 4-year period. With regards to psychosocial services in supports in the community, there is that large unmet demand, and I think here we've looked at the people in SHS support and those who were identified as needing or requiring psychosocial supports. Only 43% of those clients were actually being provided with that. So leaving a gap of over half of the clients were actually without the psychosocial supports that needed, and really reinforces the need for those comprehensive psychosocial supports and those HASI CLS type supports. Return on investment is something that's often used and highlighted by government as a useful part of investing in different programs and understanding what benefits and costs can be avoided in the broader service system. When we look at the HASI CLS program, return of investment for almost $2 in the medium term over a 4-year period for every dollar invested. So when we look at the program cost per individual of $35,000, it's not a small program, but actually the returns doubling that. So the savings that are incurred across the system. Importantly here, the recommendation has been over 356 million investment to provide for 10,000 additional HASI CLS packages for people living with mental ill health to be supported in the community. And that would ensure that scaling up and the actual capacity of those services to meet the needs and actually reduce the gap for people who are currently not being serviced and supported adequately in the current service system. Next, I'm going to talk about the step up and step down services. Interestingly, I think in most jurisdictions, when we look around Australia, there's actually quite comprehensive cover of prevention and recovery services, step up and step down services, and they're called a variety of different things around different states and territories. There's been comprehensive studies done now over a number of years across Western Australia of the program that sits in inner Sydney and also in Queensland. And I think where we look at the benefits here, there's certainly a reduction of acute inpatient bed days. There's certainly a degree of improvement that people see, significant improvements around their own psychological well-being. I think importantly, that self-efficacy and the ability to actually adjust back into the community. And importantly, I think that the recovery focus of these services really seen in supporting people's actual recovery journey. So that dedicated focus of the services being able to support people in a longer term vein away from emergency departments and acute hospital environments. Despite the success of step up, step down programs, New South Wales only currently has 5 step up, step down services, noting that there has been repeated calls for expansion of this. When we look at the need for services in New South Wales, if I contrast this with, for example, Victoria, we looked at the services per capita, so looking at the number of step up, step down services on a per head basis, where we can see New South Wales really quite low when we compare, for example, Victoria in the extreme, who've got quite a comprehensive number of park or step up, step down services, 26 for the state, and contrast that with the 5 for New South Wales. The heat map that we've got in the detailed report is further detail, but really there's an opportunity to expand these services for New South Wales and actually be able to align that with need, where we look at, for example, one of the key demands and drivers, people who are currently presenting for mental health related presentations to emergency departments. And this map just highlights some of those areas where there is greater need. So when we look at the North Coast, Murrumbidgee and Western New South Wales, the Hunter New England regions, for example, but a number of others, highlights that need. And really the investment here has been focused on looking at an additional 130 step-up, step-down places, which would be approximately 13 new services if you look at the average of 10 places per service. And that would be an additional investment of 18.2 million per annum. So a small relative investment for extensive number of places, and I think an added pathway for people in terms of being able to avoid acute hospital admission, but also actually step down from acute services sooner rather than not having options post the admission to acute services. And again, the short-term return on investment for money invested into the program pays for itself at that $1 return, but longer term, we actually see the benefits really enhanced. So people's stability, the evaluations that we've seen around the improvements in work, social adjustment, coming back into life and their levels of psychological distress, really promote those longer term benefits. So when people are actually re-engaging meaningfully in their community and society more broadly with those employment and other gains too. The third area is youth services. Here we've looked at the range of services that are available, and we note that there's been an investment in a number of programs across Australia and also New South Wales relating to young people. However, as for example, headspace programs, there's early intervention, preventative services like the Batir and Reach Out and others. And then at the high acuity sort of end, there's obviously CAMS and KIMS services, but also online support and some of the Lifeline services. But there's really a gap in that area of people who are requiring more support than can be provided in services such as Headspace, as an example, where they need greater levels of support, and it's psychosocial support, so beyond just a clinical or psychology-based package of care. And I think here, one of the key drivers again is that young people are overrepresented. More than a quarter of all emergency department presentations related to mental health conditions are young people in that under 25 age range. And I think as well, while we see greater rates of community mental health contacts and services, it's not having the impact and we're not seeing the outcomes and benefits for people, and really highlights again that sort of missing gap of dedicated psychosocial supports for young people. And I think that's been further challenged in the recent statistics that we've seen highlighting the disproportionate impact of COVID on young people, their levels of loneliness, depression, anxiety, and actually the limitations they've had on social connections and experience higher rates of mental distress. Here we've identified the need for 10 specialist youth youth services to be located around the state. That would be an investment of $14 million. It would provide an enhancement based on the existing youth support services, but actually build on because at the moment the models, whilst they're having a positive impact, they are tailored, they are co-designed with young people, they are youth-friendly and, if you like, not the sort of adult-based services that don't really talk or attract or feel safe for young people. They are small, and when we look at the numbers of staff provided in those services, as an example, we're looking at 3 FTE, and to build a sustainable model, really needing to round that out to, again, not a large number, but actually enhance that to 6 FTE and broaden out those services across the state to better meet the needs of young people for, again, that sort of modest investment year on year of 12 million. And finally, the workforce. There's been a number of strategies and plans, both nationally and at the New South Wales level, focused in on the broader mental health workforce. And I think it's important we note that the community managed sector is a significant component of the overall mental health workforce, so more than 1/4 of the overall workforce. And it's seen a steady increase of just under 13% over the past 2 years. However, there remains a number of gaps and vacant positions, particularly when we look at rural and regional and remote areas in New South Wales. And there's a greater need for ongoing and enhanced staffing across the spectrum of care that the community managed sector provide. I think here there's been some really positive work done for the New South Wales Strategic Framework and Workforce Plan that runs until 2022, looking at the attraction and career development, the training opportunities, and the distribution of workforce. And I think importantly, that's a broader multidisciplinary care. What we are suggesting here is really strengthening that workforce planning and forecasting to better project the demand for the mental health workforce, and I think in particular the community managed workforce. So looking at addressing the current gaps and issues and those vacancies, and also looking at building a sustainable community managed sector workforce into the future with those enhanced career pathways, more dedicated resources and backfilling for those training necessities, but also the development of a dedicated peer workforce and programs allowing peer workers that career structure and opportunity to actually see that, and more broadly attracting people to the community managed sector in mental health. So I think the key aspect here is really we've got a model and had increased investment, but really the need for that investment is not only ongoing, but also needs to be boosted to actually keep up with the demand and the future population growth that we're seeing across New South Wales, and importantly in those rural and regional regions. And on that note, I might stop sharing my screen and I'll pass back to Carmel. Thank you.
Great. Thanks, Andrew. That was a very comprehensive walkthrough of the report. Yeah, really appreciate that. And just so people know, the report is available. You can click on the link in the chat function, but it's also up on our website. I should make the point that the report doesn't try and cover the field in terms of every area that needs investment in mental health services, every area that needs enhanced funding, enhanced services. What we've tried to do is focus on 4 key priorities that we know are important to the organisations represented by the Mental Health Coordinating Council, but that we also believe would make an enormous difference if government would invest in the ways outlined in the report. So we're now going to move into a panel discussion, and I'd ask for Priscilla and Peter to join us for that panel discussion. I can see already that people are putting questions and comments in the chat and the Q&A function. So please keep that happening, and we'll keep an eye on that and try and incorporate that into the panel discussion. So as I said at the beginning, we're now joined by Peter Gianfrancesco, who's the Neami State Manager. Peter has over 40 years of experience in the mental health sector in both Australia and the UK. So welcome, Peter.
Let's go.
And we're also joined by Priscilla Brice, who is the relatively new CEO of Being Mental Health Consumers, but already making her mark. And prior to her role at Being, Priscilla spent over 15 years managing social change projects in the not-for-profit sector. So welcome, Priscilla. Okay, so we'll move into the questions. Peter, maybe first to you. The report identifies that we need increased investment in community mental health services. I don't think any surprises there for anyone on this panel, but do you see the need for an expansion of programs such as the HASI CLS program? And if so, what would you think would be the benefits of such an expansion?
Thank you, Carmel. Hi, everybody. Look, I think Andrew's summary of the report mentioned some of the things that tell us that the HASI program is highly effective. It makes a real difference to people's lives. It's almost unique in Australia now to have such a program funded by the state on this scale. But there are a lot of people who would benefit from HASI who simply can't get access to the program because it's at capacity. And what we know is that when people are in the HASI program, there's a real strengths-based, recovery-focused approach that helps people recover, helps people move through the program onto more independent living, to employment, often with better physical health, better connection to community, and all those things really do pay off in the long term. And there's a lot of evidence now that the HASI program not only works for the people who are in it, but for the system as a whole in reducing demand on ED, general practice, inpatient units, and the public mental health system. And I think probably the main reason for arguing that the HASI program, the HASI and CLS program, should be the type of service that's expanded to meet the unmet need is that it is a really well-established program that is really well governed, and great collaboration between the CMO sector, Ministry of Health and LHDs. There's great data, and it's a really stable, mature program with a very experienced workforce. So it would make no sense to do anything else than just expand what is a unique and excellent program.
Yeah, thanks, Peter. And I would say if anyone hasn't had a chance to have a look at the evaluation of the HASI CLS program, it's only recently been released. It's on the Ministry of Health website and well worth a read. There's an easy read version, and it's got some great data in it. I do note in the chat function that people have also made a reference to the FAMS program, which was a Commonwealth funded program, which I think worked a little bit similarly to HASI, which was abolished a few years back. It's been replaced by a different psychosocial support program. But yes, an absolute important point that those sort of programs also can make a real difference to the social supports that are available to people in the community. So Priscilla, I might turn to you now. What reforms or initiatives are your members telling you that they think would make a difference to their recovery outcomes?
Thanks, Carmel. So recently, Being actually sent out a survey to all of our supporters, and I guess the priority issues that they would like to see are probably no surprise to people. The seclusion and physical and chemical restraint only to be used as a last resort. Increasing the number of psychologist visits. So I know that this is a Commonwealth program, but essentially during COVID, we were all able to get 20 psychologist visits under Medicare, and that is now about to be reduced back down to 10. And And the other area would be emergency service workers being accompanied by a mental health worker when responding to a crisis. And that's really important because they're often the first person at the scene. There are a couple of other areas which I think tie in really well with this report being released today, and that is to strengthen community health, community mental health. So community peer workers can support people, and those particularly on a community treatment order who aren't in a crisis. And the other area is educating the sector so that peer workers are respected and are integrated within the medical models. That is very important to be able to support peer workers.
Yes, thank you, Priscilla. And you're right. I think one of the real positives of the mental health landscape over the last 10 years has been the growth in the peer workforce. And I note again, I think someone put it either in the chat or the Q&A about whether the report provides a breakdown of the workforce and identifies the benefits of peer workers and their needs. So this report doesn't provide a breakdown of the community managed mental health workforce, but we do have a workforce report that does do that. We survey our members every 2 years to be able to get an up-to-date breakdown of what the mental health workforce looks like in the community space. So that's available on our website. But the report certainly talks about the need to expand the peer workforce and the benefits that workforce brings to mental health services. So, Andrew, I think Priscilla and Peter have both identified that, you know, increased investment in different areas would be necessary. But we also know that in terms of at least community managed mental health services, New South Wales has has actually the lowest per capita investment in this space. I mean, not the lowest per capita investment in mental health services overall, but in New South Wales, we do have a much heavier balance towards the acute end of the system than the community-based system. You work across Australia. What are you seeing that's happening across Australia that we might be able to learn from in New South Wales?
Yeah, I think there's probably a couple of things that are happening nationally and then also at different states and territories that it's just worth considering for the New South Wales context. I do think that we've seen increased interest, focus and investment more broadly from both a kind of Commonwealth level and a state level in a number of jurisdictions following really, if we look at the Productivity Commission of a couple of years ago into mental health, the Royal Commission in Victoria into mental health, and then more recently the Mental Health Select Committee in Queensland that have really driven state-based and also, I think, informed some of the current bilateral negotiations and agreements that are happening between Commonwealth and state in terms of the investment. So I would say probably the things that we have seen shifting, and probably the biggest change that we've seen is for both Victoria, which is now in place, there's a payroll levy that's been included following the recommendation of the Royal Commission there. And what that does effectively is put a payroll levy onto the largest businesses within the state who are paying payroll tax. And as an example, in Victoria, we've got, I think for those businesses that have got a return of over $10 million, there's a 0.5% payroll surcharge, and then it goes up once businesses get over $100 million in terms of revenue to a 1% payroll surcharge. So what we see is effectively a levy being placed on some of the really larger and often multinational organisations, and that funding then goes into dedicated mental health resourcing. And I think that's provided that sort of boost to particularly the Victorian mental health service system, and I think we're still seeing that flow through. And the intention in Queensland is to do the same, and that comes into effect in January next year for Queensland, where they're doing a similar announcement. And really, the government there have looked at, well, actually, this is a small impost on those businesses who are large and successful and can afford to pay that levy and dedicate those resources into the mental health system more broadly. So an ability to do that, but also to build that year on year, so away from the kind of capital spend and sort of building things and then not having that recurrent if you like, expenditure built into the overall service system. So I think that's probably the biggest trend we're seeing, is that kind of overall focus and attention and kind of, dedicated plan that we've seen in Victoria and Queensland in particular, but also those sort of new ways of potentially funding services.
That's interesting, Andrew. I mean, obviously a cost to business if there was such a levy, but we also know with that NCOS report that was released earlier this year that there's an enormous cost of sort of absenteeism and presenteeism from people struggling with mental health issues. And if we could get those services in place, then businesses along with the community would reap that benefit.
Absolutely. And I think, one of the things that's really coming up in terms of the framing and discussion about the levy type approach is that actually that investment will ultimately, be far outweighed by the benefits seen to the broader economy and actually supporting people better, earlier, more comprehensively in an enhanced mental health service system that actually flows through directly, as we know, into the economy, into employment, and also into people's decreasing rates of absenteeism, presenteeism, and actually enhances ultimately the workforce. And I think that's something we often forget, the kind of almost the basics and fundamentals of actually, good work is good for our mental health, and similarly, good mental health is actually good for our employment and our jobs and our careers. So I think something that's really, important and fundamental, that's actually kind of baked into the, now 2 states and territories across Australia.
Yep. Yeah, absolutely. And I noticed that that NCOS report, the aftershock report, has just now been put in the chat function. So if anyone's interested in that report, you can access it through that link. Priscilla, that NCOS report, in fact, particularly focused on the impact of COVID-19 on people's mental health and other areas of social policy, but particularly mental health. And I think the presenteeism and absenteeism figures really did relate the cost of that to just the impact of COVID-19 on people's mental health. So, from your perspective, what are you seeing as the impact of COVID-19 on people? I mean, we always like to think we've moved beyond it, but then we kind of get pulled back into another wave and know that we haven't. And what do you think we've learnt from all of the challenges over the last couple of years about how to improve service delivery?
I think from an organisational perspective and from Bing's perspective, one thing we have definitely learned is how to work differently. So, for example, even simple things like using technology to expand our reach and provide services. I think that's now baked into how most of us, if not all of us, are delivering mental health services. Although we are bearing in mind the fact that there are some people who still would prefer to engage with us offline. So we're still grappling with that and how we are able to service more people, with varying needs, I suppose. I guess too, as an organisation, we're mindful of the significant and ongoing community mental health challenges as a result of the high levels of stress caused by the pandemic. But I would add to that also the floods and the bushfires that we've had over the past 5 years. So in summary, climate change. And so we think that that's just going to continue over future years. So we're also thinking about that strategically and how we can continue to support the community. And I would also add to that too, that services need to be more mindful and adaptive to current affairs, even globally. So for example, wars overseas, what's happening in Russia at the moment, I think that also impacts on people's mental health. And so as a sector, it would be good for us to all think about how we can create services that are that suit people where they are and how they like to use services. That a static, one size fits all service doesn't really work anymore.
Totally agree, Priscilla. And I think, very, very correct to raise the impact of the natural disasters, the bushfires, the floods. I mean, when you see what people, in the central west of New South Wales are dealing with, people in the northern part of the state and other flood affected regions, your heart just really goes out to people. It is so tough. It is so tough on the individuals who are affected. It's so tough on the services who are working in those areas, trying to stretch what they do to cover all of the need. And, if anyone's online who is either living or working in those parts of the state, please know that our thoughts are with you, and we know how tough it is. Peter, just to move into a different part of the report, Andrew mentioned in his presentation that at the moment we've only got 5 step up, step down services in New South Wales, and they're really not part of a network of services. They've kind of happened more as a response to local need from an innovative service provider. And the report calls for a network of services across New South Wales. Can you talk a little bit more about how these services operate?
Sure, Carmel. I'm a huge fan of this model. And we have very few of these services in New South Wales, but it is worth saying that the ones we do have, some of those have been operating for as long as any of these services have elsewhere in Australia. So we actually have a fair bit of experience in terms of how to operate these services and really good idea of what impact they can make. So what I really like about these services is that I think throughout my career, probably the one thing I've heard over and over again is that for consumers, the most traumatic part of the system is often getting to hospital, being in hospital, and then getting out of hospital. And what these services offer is essentially another much easier pathway to get fairly intensive support that includes many of the things you would, expect to have in an inpatient unit, and that those services can be accessed in a much less traumatizing, much simpler, much more direct way. And then people can stay in that environment in a much more supportive, collaborative, community style relationship with others who are there and with the team, the staff. The work that gets done is really about it's not really about working towards leaving hospital, which is primarily what happens in an inpatient unit. It's a lot about getting out of hospital. It's about focusing on things that help you live better out of the subacute or step up, step down unit. So a lot around resilience, a lot around community connection, a lot around problem solving, a lot around safety planning. And the most important thing is that people that use these services often report having a really good experience and want to use them again. And the good thing about that is when somebody needs that service again, typically they're going to access it earlier and easier, which means the issues will be less acute, they'll resolve faster, and the experience becomes even better and better as time goes by. And so these are great services. When they're operated by CMOs, I think they're at their best. And particularly in rural and remote communities, they're life-changing for people in terms of being able to stay near home, near to family, near to work in their community as they recover.
Thanks, Peter. And of course, the report demonstrates that, they pay for themselves within a year, and the return on investment is very high. So Andrew, maybe just to go to you on that, because you have assisted, or KPMG have assisted, providing an economic lens to the priorities outlined in the report. Can you maybe talk a little bit more about what that means, what a return on investment means, and why it matters? And I've also noticed that there's a question in the chat function that you may be able to assist with, and it's one that we struggle with a lot, and that is that, if we do raise additional money from levies, etc., how do we ensure that that ends up where it needs to be in the community managed sector, rather than being siphoned off to other parts of the system? I don't know if you can answer that second one, but it's an important question.
Well, maybe I'll go to that second one first, because I actually think what that kind of needs is to be baked into the legislation around the levy, to say where that money should be spent. I think importantly, in both the Victorian and Queensland example, it's dedicated to mental health services more broadly, so it doesn't get down to that level of which components or parts of the mental health service system are there. So I think that's a definite consideration. I think there's definitely a need for, I suppose, a considered debate and discussion about the proportion of spend currently, and I suppose if there is any future levy in New South Wales, well, what does that kind of continue that disproportionate spend on on clinical and acute services versus mental health community-based or community support services? So I think making sure that doesn't bake in some of those long-standing disparities is probably a really critical aspect. But I don't see any other way around it for other than actually being baked into the actual legislation. But also, I think that goes to the broader overall service planning process in New South Wales, and the kind of the agreements that are reached about change over time. It's difficult to say, well, no, we're not going to fund these services anymore. But actually, what often happens is we need to look at, well, what can we do to actually increase the funding to community mental health services over time, and how do we bake that in over a 5-10 year period? So I think there's probably real opportunity there, but I don't know that there's a perfect science around it at the moment. On the other question of return on investment, I think it is an economic lens that really is applied to different services that are funded, to say what does it cost to run this service. So in terms of the staffing costs, the capital, the building costs and the like, and per person. So, if we have 500 people in a year that we service, how do we apportion that? But then looks at the other side of that in terms of the benefits and the avoided costs. So benefits are often looked at from the perspective of if people are, for example, re-engaged with employment and earning an income, if they are providing support in the home and other services that actually would otherwise have to be paid for. And then also we look at the costs avoided. So if there are reductions in acute hospital admissions, emergency department presentations, and other areas of the sort of broader health, corrections, justice, so where people have avoided costs or not gone down a certain path, we look at those avoided costs and say, well, the return for government in terms of the avoided costs and the benefits directly equal a dollar number, and how does that compare to the investment we've made supporting that service? And I think it's important to note that that's just one economic analysis that can be applied. I think it's an increasingly important one for government to understand both the cost side and the benefit side. And it's a simple one for people who are not deep in the kind of financial details to kind of get across and compare different programs. I think, though, we really do need to make sure that, yes, while it's important and it's useful, that it's only one part of what we need. And actually there will be programs, there will be services, for example, in different areas like cancer support services, in terms of orthopedic areas where we actually pay for things that don't actually have a positive return on investment. They'll never make that benefit back. Sure, it might cost us, let's say, $20,000 to replace a knee. Actually, you don't physically ever get that benefit back, but actually the quality of life and the improvements made, we invest in that as a society. So I think it's important not to say a return on investment and that's it, but it is a useful tool, and I think a kind of a useful one in terms of comparing and understanding the costs and benefits of programs consistently.
Yes, good point. And there was a question in the chat function about whether there'd been an evaluation of community hubs. My understanding is the Like Mind pilot in New South Wales has been evaluated, but the evaluation's not yet been released, but I believe it will be released fairly soon. I'm not aware of other evaluations, but I'm sure that they do exist. And there was also a question about whether there's a map about where community hubs are across Australia. There's a few new ones being established in New South Wales as a result of the bilateral agreement. But again, I'm not aware of a map as such, although there might be something on the Commonwealth website. We can check that out and let you know. So we've got 5 minutes left. One critical area, obviously, with any expansion of mental health services is having the workforce in order to be able to deliver those services. And we know that at the moment, the community mental health sector, like so many other parts of New South Wales, Australia, are struggling with workforce issues. So maybe to Peter and Priscilla, what do you see as some of the opportunities and challenges to ensure that we do have the workforce we need for the future if we are going to expand services as outlined in the report? Maybe to you first, Peter.
Thanks, Carmel. Yeah, look, I think that we're probably, all aware that there have been some real challenges with the workforce over the last couple of years, and there's all sorts of reasons that compound that, like short contracts and casualisation and those sorts of things. I'd like to focus on what I sort of think are some of the real opportunities that are emerging for the CMO sector and the workforce. So the first thing would be just the growth of the peer work and lived experience workforce. I've seen really rapid growth in our organisation, but it does create challenges in terms of being able to provide, access to qualifications and certification and credentialing for that workforce. That's going to be really important moving forward. And I think it's also going to be really important for organisations to reflect the lived experience workforce in the way they lead and manage and govern the services they operate. And the other thing I wanted to just mention is the other growth I see is in a clinical workforce. And, we're seeing a whole lot of programs being funded now that require the CMO sector to employ clinicians. And I think that's a really good thing. It's quite difficult to do at times, but it does provide some really great opportunities for new models of workforce mix where lived experience and clinicians work together in sort of really, really integrated ways. And for me, that's really exciting because it just breaks down a lot of the traditional barriers between public mental health system and our sector.
Great, thanks, Peter. And Priscilla?
Yeah, absolutely agree with Peter's point there. I think that there is still a lot of work to do, especially to ensure that the clinical workforce understands the role of peer workers and that they're respected within that clinical model. And I'd also add that there is still a need for better supports for peer workers, including availability of peer supervision and access to collegiality. That this is something that comes up often in conversations with our supporters, that peer supervision is necessary and it needs to be prioritised more than it has been. Bing has been doing a little bit of work around that, but I think as a sector, we could do much better in supporting our peer workers.
Yes, agree, Priscilla. And the issue of peer supervision has also come up regularly with MHCC in terms of, we deliver the certificate for mental health peer work course, and often the participants in that course are raising that issue of, what follows and what sort of supervision is available for peer workers. So I want to thank our panelists. This brings us to the end of our time for the webinar. I do just want to note one other issue in the Q&A function where Elizabeth has raised the need for multicultural communities to be included, pointing out that Southwest Sydney was the most negatively impacted by COVID. Yeah, agree, Elizabeth. One of the recent developments of the HASI CLS program was the HASI CLS for refugee communities. And while it's relatively new and it only supports a small number of people, again, the feedback has been incredibly positive with regards to the difference that program makes. And the access to it is slightly less constrained than the access to the other HASI CLS supports, so it's more accessible. So I totally agree. And if we were to get the priorities realised in our report for an expansion of HASI CLS packages, that would enable that area to be expanded as well. So look, thank you. There are other questions and comments in the chat function that we haven't got to, but we will endeavour to get to those. I really want to thank our presenters and panellists, Andrew Dempster, Priscilla Brice and Peter Gianfrancesco. Thank you very much for joining us today. I also want to thank the members who were a part of the working group that assisted us develop the report. There's too many to name today, but your names are at the front of the report, and we really appreciate your input and support for this project and for the development of this report. As I said, the report's available on our website. There's also a link to it in the webinar chat. It will be shared through our social media channels. So please, if you follow us, can you share it and reshare it? That way more people get to know about it. If you don't follow us, can you start following us? We want to increase our following on social media. But yeah, look, I think this is a really important contribution to the debate about increasing community services and highlighting the really important work that is done in our sector. Thanks everyone for joining us. Have a great day. Bye.
Bye.